Hello, everyone. My name's Apondi Odhiambo. I'm a PhD candidate at the Lalana School of Public Health, University of Toronto. I am so happy and honored to share my work with you today. The topic of my presentation is law, HIV care, and undetectability, looking at the social organization of HIV healthcare for African, Caribbean, and Black people living with HIV in Toronto. This work is part of a larger study called Actioning Black Health Study, or in short, ACB Health Study, which is my dissertation work. Before I proceed, I would like to state that I do not have any conflicts of interest. Black communities consisting of people of African descent, majorly from African and Caribbean countries, are structurally disadvantaged and bear a disproportionate burden of HIV. Black people account for 30% of the HIV prevalence and 15% of new infections, despite making up less than 3% of the Canadian population. In Ontario, Black people account for 30% of the HIV prevalence and 25% of new diagnoses, despite representing less than 5% of Ontario's population. Biomedical discourses and HIV healthcare and treatment practices and scientific evidences have long established that people living with HIV who are engaged in HIV healthcare and are on antiretroviral treatment and adhere to the treatment can achieve viral suppression or a state of undetectability, which is fundamental for optimizing health outcomes, decreasing HIV-related mortality and morbidity, and preventing onward transmission of the HIV virus. However, Black people living with HIV face health inequities that increase their burden of living with HIV and impact their efforts of access, engagement, and adherence in HIV healthcare and treatment. The SCB Health Study used institutional ethnography as a conceptual framework and method of inquiry. The study problematized how efforts to manage HIV/AIDS ignore inequities shaping the social world of Black communities. The specific research question and problematic area we were concerned with was how laws and institutional practices shape and constrain HIV healthcare for Black people living with HIV in Toronto and impact their efforts of achieving undetectability. We conducted a total of 35 interviews, 20 with Black people living with HIV, including immigrants with precarious immigration status, and permanent residents and citizens experiencing precarity. We also interviewed 15 health workers, including healthcare providers, panel physicians, policy health actors, and frontline workers based at AIDS service organizations and community-based organizations. We further conducted a textual analysis of legislative frameworks and policies that organize immigration, healthcare, public health systems, and practices. We also looked at biomedical discourses and practices of HIV, particularly guidelines, protocols, and scientific research findings. We also looked at international discourses and frameworks on HIV response and human rights. This study established a disturbing disjuncture between the work process of gaining linkage and engagement in HIV healthcare along the cascade and achieving undetectability and the day-to-day realities of Black people living with HIV. In particular, we found that inequities at the intersection of Canada's immigration, public health, and healthcare legislative frameworks and institutional practices presented barriers and missed opportunities to timely linkage and engagement in HIV healthcare. Mandatory HIV testing under immigration medical examination policy was a major barrier to linkage for Black immigrants who had arrived in Canada knowing their HIV status, or those who discovered their HIV status through the immigration examination process. The study found that mandatory HIV testing was conducted among Black immigrants without their informed consent and without pre and post counseling. Furthermore, there was lack of referral and linkage to care by the panel physicians following a positive diagnosis. The data revealed that panel physicians prioritized reporting of new diagnoses to public health over linking Black immigrants to care. The problematic encounters with the immigration panel physicians and the immigration system produced fear and stigma. These encounters also negatively shaped newly diagnosed immigrants' attitudes and decisions to access HIV healthcare. This legislative practice presented missed opportunities for linkage and engagement in care. A Black immigrant who was diagnosed with HIV through the immigration medical examination process stated, "I did not know what to do because nobody told me anything. The immigration doctor just gave me an address and said, go to this place, go to that place." Navigating that, getting around without resources, and getting to know where to go was quite a challenge for me. This narrative and many others revealed that Black immigrants' experiences in Canada, coupled with their lack of knowledge of Canadian healthcare system and the punitive legislative practices of the immigration policies, negatively shaped their attitude and led to avoidance of timely linkage to care. Public health policy and practice of contact tracing and partner notification was also a barrier to linkage to care for Black people living with HIV. The participants narrated how they received random, threatening, and stigmatizing calls from public health agents. These calls interrogated them about their sexual practices and sexual partners. The calls were also threatened Black people about criminalization of HIV non-disclosure. These experiences negatively shaped newly diagnosed immigrants' attitude as well as Black people's attitudes and decisions to access HIV healthcare. Black people were concerned about privacy and confidentiality due to the punitive and policing nature of the public health practices. There was also fear of exposure to the migration, loss of immigration status, and deportation. Furthermore, the data revealed that those who were called by public health agents did not receive any referrals or linkage to care, particularly for those Black people who had no experience or knowledge of how to go about accessing HIV healthcare. This presented a major barrier and opportunity to linkage to HIV healthcare. A Black man living with HIV stated, "You cannot pass such an important information over the phone. That right there can damage someone for the rest of their lives. The first person you are in contact with determines how you access services in this country. It can make someone just run and hide because they threaten to report. They, public health agents, use words like surveillance. Where I am coming from, those are harsh words. It's like somebody will be following you and knowing what is going on or happening. Who knows? How are they going to use this information? What will happen to me?" This narrative and many others revealed how the policing and surveillance nature of public health system presented barriers to timely linkage by instilling fear and threats to Black people living with HIV. Inequities and gatekeeping practices within Canadian healthcare system were also barriers to timely HIV linkage. Complex, bureaucratic, and patchy healthcare system presented major barriers. The Black people stated or narrated how they found it very difficult finding a doctor, booking appointments, and they experienced long waiting time. The 3-month waiting period of Ontario Health Insurance Plan that requires people who receive permanent residence or those who are coming out of province to wait for 3 months before accessing treatment, healthcare or treatment through OHIP was a barrier to linkage to care for those Black people who are coming out of province into Ontario. Some of the participants that we interviewed stated how their treatment, their taking of antiretroviral treatment was interrupted during the 3-month waiting period. All the Black people we interviewed in this study did not have any form of drug coverage. Black people stated how they relied on Ontario Disability Support Program to access drug card and access gain coverage for antiretroviral treatment. More so, Black people expressed that the reliance on the welfare system for treatment made them feel trapped within the welfare system. This was because Black people were not able to, Black people feared seeking employment because they felt that if they seek employment and gain income, they may become ineligible for Ontario Disability Support Program. Those who opted to seek employment stated that they had to drop out of the welfare system and as a result face barriers to accessing antiretroviral treatment. A few of the participants that were interviewed had stopped taking their antiretroviral treatment because they could not afford out of pocket. Black people also expressed fear, stigma, discrimination, and anti-Black racism while accessing healthcare and welfare support services. This stigma and discrimination and anti-Black racism, coupled with the complex, bureaucratic, and patchy healthcare system, led to avoidance or delayed access to HIV healthcare and treatment. One healthcare provider that was serving Black people living with HIV in Toronto stated, for immigrants who need medication and have absolutely no coverage, one has to figure out what they're going to do to access their HIV medication, which could be really challenging. We have to scramble around to somehow get way to get them on treatment. This narrative of healthcare provider and many other narratives between Black people and other healthcare providers revealed how Black people had to go through very messy, bureaucratic, punitive, and anti-Black racist procedures to access treatment through the Ontario Disability Program, as well as through community healthcare centers. This map shows the disjuncture between biomedical discourses and practices and the day-to-day experiences of Black people living with HIV who are seeking healthcare. The assumption that people who are diagnosed with HIV in Canada automatically accesses HIV healthcare and treatment and achieves undetectability was debunked in this study. This map reveals how the work process of gaining linkage to care and engagement in care is interfered with or constrained by legislative and institutional practices right here. And this section highlights several legislative barriers and institutional practices that constrain access, engagement, and adherence to HIV healthcare and treatment for Black people living with HIV. Consequently, it reveals the health outcomes that emerge as a result of these legislative barriers. Among them, missed opportunities for timely linkage and engagement in care, avoidance or delay in accessing HIV healthcare, late initiation of antiretroviral treatment, lack of or delayed treatment of comorbidities, exacerbated mental health issues, lack of viral suppression or inability to arrive at undetectable viral levels, poor health outcomes, and violation of human rights. In conclusion, despite national and global initiatives to end HIV epidemic, Black people are still being left behind. Legislative frameworks, policies, and institutional practices of regulating these systems interface to constrain Black people's effort to access, engage, and adhere to HIV healthcare and treatment, and reach and or maintain undetectable viral load levels. Structural violence resulting from unjust legislative frameworks produces health disparities and inequities, leading to the violation of Black people's right to health. As a result, Black people continue to experience poor health outcomes and health. Therefore, for Canada to achieve the global targets and end HIV leaving no one behind, it must start actioning Black health now. The government must ensure non-discriminatory, timely, and quality and equitable access to healthcare services, including HIV healthcare. There's need for development and implementation of integrated system that ensures access to comprehensive and universal healthcare services. There's also need for culturally relevant, responsive, and safe services. Most importantly, there's need for implementation of a national pharmacare plan that will help address inequities and disparities in drug coverage. I would like to acknowledge Black people living with HIV, healthcare workers, and policy health actors who participated in the SCB health study. I would also like to acknowledge my PhD dissertation committee, Dr. Daniel Grace, Dr. Lisa Foreman, Dr. Patricia Campbell, and Dr. Lauren Nelson. The Actioning Black Health study was supported by the Canadian Institute of Health Research and Ontario HIV Network. Thank you so much. For further information about the SCB Health Study, please look at the website actioningblackhealth.com or contact me through the email provided. Thank you so much.